All right. Good morning, everyone. Welcome to the Women's Health webinar hosted by Target Physio. My name is Jenny Oakley, physiotherapist at Target Physio, and today I'll be running through the antenatal case. Now, if there's any questions you have throughout the webinar, please post them in the comments and we'll get to them at the end, but I'll pass over to Heather to do a little intro.
Hi, I'm Heather Butterworth, also physiotherapist at Target Physio, and I'll be running through the postnatal pelvic floor case today, and then we'll hand over to Fee.
Yes, good morning. I'm Fiona Pringle, part of the Target Physio team, and looking forward to taking you through a postmenopausal case a little bit later.
Alrighty, so what I'll do is I'll just bring up our slides, which have, there we go. All right, so yes, I'll be starting us off with the antenatal case, but first let's just get a little bit of an intro to the pelvic floor. So, here we go. So, yep, that's all of us there. And okay, so pelvic floor, what is the pelvic floor? So the pelvic floor is the group of muscles in the base of our pelvis. And so it has roles when it comes to continence of the bladder and the bowel, our pelvic organ support, so an anti-gravity role as well. It's important for our sexual function, so with sensation and arousal. And it also provides some musculoskeletal support in combination with the abdominal muscles, the spinal muscles, and also the diaphragm. And it's important for withstanding increases in intra-abdominal pressure. So for example, when we cough, sneeze, or lift. So what things can affect our pelvic floor? So being pregnant and going through the process of childbirth as well, whether that's through cesarean or vaginal delivery. Having an increased BMI or body weight can place an increased downward pressure on the pelvic floor. If you have a chronic cough or a respiratory disorder, so having frequent coughing or chronic coughing increases that pressure in the tummy, so can have an increased demand on the pelvic floor. If you suffer from constipation or straining, that can place increased pressure on the pelvic floor. There's also some changes to the muscles and the connective tissue as we age and go through menopause, which Fiona will discuss later. Pain can also contribute to our pelvic floor function. And also having a lack of physical conditioning. So if we have poor lower limb muscle strength or pelvic strength or abdominal strength, that places increased loads on our pelvic floor. So let's start off with our antenatal case. So this is Peta, and Peta is 27 years old. She's currently 26 weeks pregnant with her first baby. She's a part-time hairdresser and is due to start maternity leave at 34 weeks. She's currently experiencing some left-sided lower back and pelvic pain, which she notices more so when she's rolling in bed, going up and down stairs, and getting in and out of the car. She's also experiencing some occasional urinary leakage, which started about a month ago, and it's a one small to moderate leak on a couple of days a week, and it's aggravated by sneezing and overhead weights at the gym, and so she started wearing a continence aid to the gym. She's had no history of urinary incontinence before her pregnancy, and also has a bit of a history of some knee injuries and some knee pain, but no lower back or pelvic pain before. And she plans to have a natural delivery when the time comes. So Peta's goals include reducing her lower back pain and her pelvic pain so she can improve her sleep, but also resolving the urinary incontinence to minimize the symptoms later in her pregnancy and also when she enters motherhood. So if we think about, well, what can we modify when it comes to Peta's scenario and what can't we modify? So we know that Peta's body is going to change throughout her pregnancy, and that's those normal healthy adaptations around the pelvis, the lower back and the pelvic floor to allow for a more safe and comfortable childbirth. And then she's also got a history of knee injuries, which we can't do much about either. But what we can do with Peta is we can improve her pelvic floor muscle strength and control. We can improve her aerobic fitness, and we can improve her lower limb and trunk muscle strength as well. So currently, this is what Peta's physical activity is like. So before she fell pregnant, she was running a few times a week. She was going to a pump class at the gym and then would go for a hike on the weekend. So she was getting around 200 minutes of activity, which means she was meeting the guidelines for at least 150 minutes a week. And she was also getting in her 2 strength sessions as well. When she fell pregnant in her first trimester, she reduced the running as she was unsure if it was safe to do while she was pregnant. So she just started walking instead. And then she dropped the pump class to once a week. So she was still getting her 150 minutes a week, but she was missing out on that second strength session. And now she's in her second trimester, and her back pain and her pelvic pain is really limiting her activity. And she sees the pump class because of the leakage she was getting. So has dropped her activity to just 15 minutes of walking a few times a week. And so definitely not meeting the aerobic activity and not getting her strength sessions either. So how can physiotherapy help Peta? Well, we can help manage her lower back and pelvic pain. So retraining the tasks that she experiences discomfort with. We can also use some pelvic support garments if necessary as well, and also correct any of the underlying mechanical adaptations and movement patterns with an exercise program. We can also do some physical activity during pregnancy as well to help reduce the lower back and the pelvic pain, and also reduce any pain in the early postpartum as well. And then using some strategies at work to minimize her pain too. Specific exercise programs we can use to help manage pelvic pain and lower back pain as well. So addressing the muscles around the hip, such as the gluteal muscles and the adductor muscles. And also the pelvic floor muscle becomes very important when looking at lower back and pelvic pain as well. So pelvic floor dysfunction is present in about 52% of women with lower back pain, and it becomes a very important factor to address. Also the more active you are, the more, that you have more increased activity of the pelvic floor muscles, but loss of that motor control in pelvic and lower back pain. And there's also a frequent occurrence of stress incontinence, urgency, sexual complaints, discomfort and pain in pregnancy related to lower back pain as well. How can we help with the stress urinary incontinence? So with pelvic floor muscle training. So engaging in regular activity, including a pelvic floor muscle program, less likely to report urinary incontinence in late pregnancy. And that was found throughout quite a few studies. So able to reduce the symptoms later in pregnancy, but also into early motherhood as well. And so good point is that pelvic muscle strength is associated with urinary incontinence or continence, and not how often you exercise. So it's important to have a strong pelvic floor to manage continence. All right. Lifestyle strategies. So we'd have a chat to Peta about hydration and nutrition. So making sure she's got adequate fluid and fiber to prevent constipation. And then also having good bladder and bowel habits to reduce the strain and pressure on the pelvic floor. And then as her pelvic floor strength is increasing, we can modify some of the exercises she does at the gym to reduce the symptoms of the incontinence. So bringing the weights below shoulder height. We can also help Peta exceed the minimum physical activity guidelines, which we spoke about before, so that 150 minutes of physical activity per week plus the 2 strength sessions. So there's a good association between aerobic fitness and pelvic floor muscle strength. So usually the fitter you are, the stronger your pelvic floor. And low to moderate intensity physical activity has been associated with a range of health benefits and is not associated with adverse outcomes. And regular exercise can help reduce back pain, improve or maintain muscle tone, reduce leg cramps, swelling and constipation, and improve sleep patterns. And the Target Physio Women's Health Clinical Conditioning Program goes through a lot of these things. And then physical activity guidelines. Here's just a summary for us. So there's 150 minutes of moderate intensity activity plus strength building exercises on at least 2 days. And it's important just to adapt and respond to the changing body. If you're not sure where to start or how to keep going with what you're doing, you can have a chat to your physio, your GP or your obstetrician. And now I think that's the end from me. So I'll be moving on to Heather to go on to the postnatal case. Oh no, sorry, there's just a little bit more information about the program.
Okay, I'm just sharing my screen here. Won't be a second. Okay, so we're moving on to our next case, which is Paula. She is a 32-year-old female and she's a part-time primary school teacher. Her childbearing history is 2 vaginal deliveries, her first child when she was 28 years old and her second at 31. Her second child was greater than 4 kilos and that sometimes puts you at a little bit higher risk of having pelvic floor dysfunction, having a larger child. Medical and musculoskeletal history, she has mild asthma throughout her life and also an ACL repair of her left knee following a sporting injury when she was younger. Her current concerns that she would come to physio for is that she's having some incontinence during strenuous activity, including running, jumping, and not so strenuous activity, but when she sneezes, she feels like she has some leakage then. She has some abdominal muscle separation following pregnancy, and she's not confident about doing strengthening exercises at the moment. She's been having some low back pain and finding it difficult to get some time to get back to physical activity. But in the same time, she's also lost confidence in going to the gym. She's fearful of her back pain causing long-term damage. The goals that she had for herself, she wanted to get rid of her back pain, but her key one was returning to running to complete a half marathon. Her modifiable factors that I might actually start with the non-modifiable factors. Childbearing history, we've had kids and that's not a negative thing at all. It's just something that we can't change. She's had a knee injury in the past and during changes to the body through pregnancy. Modifiable though, these are the positive ones. These are the ones we focus on that we can make a difference with, is her pelvic floor strength and control, her lower limb and abdominal muscle strength, and her aerobic fitness. Her physical activity of history, pre-pregnancy, she her sport was running and doing marathons. She was training 5 days out of 7 and also attending the gym doing strength training. So she was meeting her requirements, of her weekly requirements, and even exceeding it with the amount of training she was doing. Post-pregnancy of the first child, her walking to around 30 minutes, 5 to 6 times a week. So that's meeting that 150 minutes of aerobic activity. And she had built back into running 6 months after the first birth. Her limiting factors at this point were her time and confidence to return to strength training. She hadn't got back to the gym to keep on her strength. Post-second pregnancy, walking was only 2 to 3 times a week and no strength training again. Her limiting factors were her time and confidence. And now she was starting to get some stress urinary incontinence with running. So she didn't feel confident to get back to that as well. This is a really common situation through our childbearing years, is we just slowly decline in our activity. Mostly because of our time that we have. We've got these 2 new children we need to be looking after and our time is limited, but also that confidence of getting back. So that's a really key one to come see a physio for. It's a really common story and it doesn't have to be. It's definitely not necessary. So our guidelines at this stage in life, at least 150 minutes of moderate intensity activity every week. And that's a minimum. You know, don't be worried if you're exceeding that, that's perfect. Daily pelvic floor exercises and strength training at least twice a week. So how can physiotherapy help for Paula? So to start with, we'll go through the pelvic floor assessment and strengthening program for stress urinary incontinence. So as Jenny mentioned before, about the pelvic floor and its function, when we are giving birth, obviously we have to have some changes to allow the baby to pass through the birth canal. So this can leave you with some pelvic floor problems following, but we're able to work on them, and an assessment after 6 weeks following birth is a really nice time to see where you're at and what we can work on from there. There's research around women participating in one-on-one pelvic floor training program. They were 8 times more likely to report a cure of stress urinary incontinence. So that's really exciting, that we don't have to put up with it during exercise. We can get rid of it, and improve continence-specific quality of life. Depending on your delivery mode, special considerations need to be made. If it was an operative vaginal delivery, we're more likely to experience pelvic organ prolapse or stress urinary incontinence, and that's especially important to come see a physio after. And the caesarean delivery, they're less likely to have stress urinary incontinence, but they are more likely to have abdominal pain or low back discomfort. And having that assessed as well before we go back to those higher level exercise is perfect to just get you on the right track and making sure that your abdominals are working nicely, supporting that lower back as well as possible. So moving from our pelvic floor assessment, we go into some postnatal strengthening programs. So commencing from the 6 to 8 weeks after the pelvic health assessment, as long as everything's going well with your pelvic floor and that we've got those exercises started, then we can start building in some strength exercises, addressing any strength and motor control deficits, pain education to build confidence in movements, and working up to power moves once we've worked through there with like hopping and learning how to control our single leg landing and ability to maintain our strong pelvic floor. So there's some research around the deep core stability strengthening program plus traditional abdominal exercises 3 times a week for 8 weeks, found that it was really effective in treating the diastasis recti, which is the abdominal separation that Paula had mentioned was one of her concerns. And also just a little bit of extra information that people who participate in strengthening programs tend to exhibit greater pelvic floor activation. It has also been found that just doing strengthening program won't improve your strengthening of your pelvic floor unless you are doing pelvic floor specific exercises. Returning to running and high impact exercise. Following on from our strengthening, we'd then be building into this running and high impact. So they can start between 3 and 6 months post-birth, depending that we have no pelvic floor dysfunction symptoms or pelvic pain or abdominal pain as well. Carefully planned out programs need to take into consideration overall fatigue when calculating loading increments. Considerations for new mums especially is sleep. There is high incidence of injury if we haven't had good sleep and we go and push ourselves at that point. Increased nutrition requirements if we're breastfeeding, making sure that we've had a good meal and also we're well hydrated. And overall mental health is a really important one to consider. Overtraining can happen if we're using our exercise as a coping mechanism. So making sure we're keeping a close eye on new mums that are returning to running, that they're using it in a healthy way, that it's not an overtraining factor. If we are time limited and we're running with a pram, then advice and technique considerations for running. We tend to have we're a bit more bent forward, we've got more hip flexion in our running, and we need to make sure that we're strong enough and that we're not making any compensations using that. Also some breastfeeding considerations. Moderate intensity exercise does not affect the quantity or composition of breast milk or impact of infant growth. So there's no putting the worry on you for that one. We can breathe easy that our exercise is doing a good thing for us and our babies. Increased hormone production during breastfeeding can result in increased joint mobility, persisting post-childbirth. So that's something we need to consider, but we'll already have looked at that through our strengthening program, that we're using ourselves well, but just keeping in mind. And wearing correct fitting supportive garments and feeding prior to running can also improve your comfort while you're trying to get back into it. So where to from here? I want all mums to prioritise their health. It's a hard one. We've got 2 little people running around that we've got to keep track of, but it's really important that we look after ourselves first, because if we don't do that, then we're not always there to help our children out as well. Aim to exceed the weekly exercise guidelines. Don't just aim for what the guidelines are, try to exceed it. Be as strong and healthy as you can. And from here to menopause, I know that sounds like a lot of planning, but we want to make sure our pelvic floor hits menopause in its perfect form. Our bone mineral density is right up there. All that exercise is maintaining it perfectly for us. And our cardiovascular fitness, we're going to run straight into it. So from here, we're going to be passing over to Fiona.
Thank you, Heather. That was very, very informative. So now I'd like you to meet Pam. Pam is a postmenopausal woman. And in Pam's story, we look at 2 things. What's not modifiable? Her age, her obstetric history, her gynae history, her fitness history, her work history. But what is modifiable? And we discover many evidence-based opportunities to help Pam, which is exciting. Now, Pam's primary problem is her urgency incontinence. She experiences sudden urge to go and leakage before getting to the toilet. She is anxious about the toilet locations and fears accidental voiding in public. She's the just in case toilet visit is a big part of Pam's routine. Pam's secondary problem is stress incontinence. It is not a major issue, as Pam only experiences a little leakage when she coughs a lot, getting over a chest infection. Chest infections and asthma flare-ups are important times to check in with a women's health physiotherapist. Here, I'd like to give a shout out to the fellow women's health physios worldwide assisting in COVID medical teams. These amazing physiotherapists are helping postmenopausal women clear their lungs and manage their pelvic floor strain of incessant coughing. Pam's primary underlying problem is her long-term physical inactivity. With only 15 minutes of slow old dog walking, Pam is not meeting the Australian physical activity guidelines for older adults. Also, when you look at the specific exercise needs to avoid urinary incontinence, Pam is missing important items. She needs to be walking at a moderate intensity for her for an accumulated 30 minutes on most days. Accurate daily pelvic floor muscle exercises are needed to help keep it in good working order. A minimum of twice weekly, Pam needs to be doing some strength exercise appropriate to her level. Also twice weekly, Pam needs to be doing a bout of specific balance exercises. Poor old Pam, you might be thinking, but if Pam doesn't want to be leaky Pam, this is a perfect recipe. So now let's look through Pam's story for all of the modifiable factors. As we look at a tiny bit of the vast body of high quality research that underpins the work of women's health physio, to get control of urgency incontinence, we know, sorry, I've mixed up my slides here. Sorry, I'm one slide ahead. Let me just go back to this with Pam's vaginal deliveries. What I wanted to comment on here was the incredible opportunity. We can't help that she's had 4 deliveries and 2 big babies, but the thing that we look for in the opportunity here is that after her first delivery, she had very nasty tears, but she went on to have very little history of stress incontinence. So it tells us something about Pam, that her pelvic floor recovered very well. We look at her gynae history, her hysterectomy. She kept her ovaries for well into her 70s. I mean, into her 50s, she would have been producing estrogen, which is exciting. Her sexual dysfunction is a problem, but we know that improving pelvic floor muscle function improves sexual function. So I think that Pam's in for a bit of a surprise. Her musculoskeletal history, her left total hip replacement and loss of mobility. There's lots of people who don't rehab fully after hip replacements. And so Pam has got some scope there too. And looking at Pam's long-term fitness history, we see that when she was younger, before she was encumbered by babies, she loved netball and tennis. After that, as Heather alluded to, very little happened. So let's go on. This is where I got my little mix up of my slides, but just looking at the urgency and the stress incontinence, the pelvic floor muscles, first of all, they bring immediate calm to the overactive bladder, but also they are necessary to lift the bladder neck and squeeze the urethra. So the challenge here is to the challenge I have for you is to say to you, when you contract your pelvic floor muscles, is what you think you're doing exactly what you are doing? Or do we just squinch and hope for the best? And what we know is that pelvic floor muscle accuracy is very important, and knowledge and feedback are key. A better understanding of general pelvic floor helps, but just knowing about where pelvic floor muscles are, what they do, and what can go wrong, and treatment options is not enough. We know now that physiotherapy biofeedback during pelvic floor muscle exercise is needed to achieve a good outcome. And our women's health program includes training with biofeedback via vaginal examination and real-time ultrasound. Now we look at this fabulous Cochrane review, which provides powerful evidence that physiotherapy-led pelvic floor muscle training is strongly associated with a cure of incontinence. There were 1,051 women in this study, and some of them were postmenopausal, but all of them had incontinence. So when we start talking of a cure for incontinence, this is mighty powerful research and brings a lot of hope to our Pam. There is also information that says that a booster pelvic floor muscle training is required, because some of these women, they showed that about 12 months, if they didn't keep up their training, their pelvic floor deteriorated. So that's normal. When the going is good, we forget about the work that it took to get there. So we've just got to be reminded. General exercise has been shown to help, but it's not enough. This 2018 study showed that targeted pelvic floor muscle training with biofeedback provided by a physiotherapist is most effective. Seeking help for urinary incontinence becomes very important in Pam's age group. And in our program, it includes a progression to general strength and fitness as the pelvic floor muscle accuracy is established. The importance of aerobic fitness. The fitter you are, and Jenny alluded to this, the stronger your pelvic floor muscles are, without question. However, we need to be careful with this. The ability to walk well, walk often, walk quickly are associated with better pelvic floor muscle strength. The caution is that a graded progression is needed when resuming fast walking. Faster walking puts greater downward pressure on our pelvic floor, so pelvic floor accuracy and strength needs to come first. And in our women's health program, we include an individualized design of a graded aerobic fitness program. Looking at estrogen, estrogen production is lowered in postmenopausal women. Lower estrogen is associated with a loss of soft tissue bulk. Estrogen receptors have been found in the pelvic ligaments and in the pelvic floor muscles. So estrogen creams are often prescribed for local application with some success in improving vaginal tissue condition. Hormone replacement therapy prescription is only recommended if they are too severe. Importantly, there's level 1 evidence that says that HRT provides little benefit for postmenopausal incontinence. So if you're considering HRT because incontinence is the issue, perhaps that should be reconsidered. Going on, in contrast, pelvic floor muscle training provides improvement in both prevalence and severity of incontinence. Pelvic floor muscle training has been shown to be more effective at improving strength and incontinence in women that are not on HRT. There are many lifestyle factors that also help with bulking up our soft tissue. Avoiding smoking and minimizing alcohol, maintaining sexual frequency and the use of personal moisturizers and lubricants. And if you consider the fuss we make about our complexions and putting good creams on our faces, you can spare a thought for other tissues in our body. Exercise is very important to maintaining or improving the quality of vaginal soft tissues. So when we put together a program, it includes specific training which is directed at improving soft tissue bulk. Looking at urgency management strategies for PAM, urgency urinary incontinence is overactive bladder. Overactive bladder is a sort of umbrella term. It refers to a neural sensitivity that can be local, i.e. generated from the pelvis, or central, generated from the brain. There's a connection between anxiety, depression, and overactive bladder. Urgency can be heightened by a sense of threat or fear, and urgency can be learned by association, like hearing water running or putting your keys in the door. Medications for overactive bladder are non-specific and are not without side effects, but they're often the immediate go-to. The good news is that the neural system is the fastest system to respond to training. And when we put together an urgency management strategy, which is individualized for a woman, we can have postmenopausal women who are struggling to leave the house come back within a week or so with dramatic changes because of this wonderful fast-acting neural system. As soon as you stimulate it differently, a different outcome occurs. Now, looking at sexual dysfunction, it's more prevalent in postmenopausal women with weak pelvic floor muscle. However, the link is weak for incontinence and sexual dysfunction. So just because you have incontinence, it does not mean that you will have sexual dysfunction. Either way, for both sexual dysfunction and incontinence, strong pelvic floor muscles are key. If sexual dysfunction is the main problem, targeted pelvic floor muscle training is of greater value than general aerobic fitness and strength. Now, if a woman has a difficulty in communicating sexual dysfunction, we use this fabulous questionnaire, the Female Sexual Dysfunction Index, which helps to communicate the difficulties. And most importantly, it helps to provide reassurance as we watch the score on that index go up with treatment. Incontinence, looking at this total hip replacement, can be worse with hip pain and restriction. Pain inhibition in the pelvic floor muscles can result. Mobility difficulties can make getting to the toilet more difficult. And at Target Physio, we run the GLAD program, which is a program designed for lower limb osteoarthritis, and it is known to improve pain, reduce the need for joint replacement, and help manage toilet accessibility issues. But if, as in Pam's case, a total hip replacement is necessary, it is associated with improved urinary incontinence due to pain reduction and mobility improvement. And as part of our women's health program, we design specific features to address lower limb strength, lower limb asymmetry, and painful lower limb arthritis. Now, this fatty infiltration I wanted to cover because if there's anything to scare a postmenopausal woman into exercise, it's got to be fatty infiltration. Now, fatty infiltration into skeletal muscles happens more with aging. If it happens in the leg muscles, it's associated with a greater falls risk. It's associated with inactivity. They've done studies on astronauts, and when they come back having spent time in zero gravity, their muscles have a lot of fatty infiltration, and that is similar to when we are very inactive. Estrogen deficiency is associated with more fatty infiltration, and pelvic floor muscles are skeletal muscles. So when you start to look at fatty infiltration, it promotes pelvic floor muscle weakness by physically obstructing the function of the muscle fibers because it gets between individual muscle fibers, by penetrating the belly of individual muscle fibers. It also, once fat is sitting in our muscles, it emits inflammatory cytokines from within the muscle. So we have this inflammatory dose in our bodies before we even begin. Because fast twitch muscle fibers are more susceptible to fatty infiltration, it tends to cause a dominance of slow twitch muscle fibers. So it's more difficult to control sudden demands for pelvic floor action, like Pam's cough. Because as fatty infiltration increases, the muscle fibers themselves decrease in number. So when we put together a women's health program, it includes elements which directly reverse intramuscular fatty infiltration, which is so nice to know that that can happen. Now, I realize that our faces have blocked out all my beautiful Pams, but I found all these ladies, on the internet, and they're all named Pam, and they all look like our category of lady. And if we look at Pam's modifiable factors, I wanted to really communicate hope to this cohort of women. These are women who just accept incontinence as part of their existence, and it doesn't need to be so. There is no age where a woman can't make some improvement in this area. And when we look at the evidence-based base that we've covered today, Pam has a very real expectation that if she can invest 6 to 12 weeks of effort in a women's health program, she's got some real scope for a life-changing improvement. Thank you. Right, over to you, Jenny.
Thank you, Fee. What I'm going to do is we'll just pop through the last couple of little slides. So this slide just shows you where you can find some more information if you are experiencing any incontinence. So the Continence Foundation of Australia and Pelvic Floor First are some great websites that have some awesome fact sheets and resources and tell you a little bit more about the pelvic floor and how it works and what things contribute towards the pelvic floor function. And then also the Target Physio website. We have some great blogs and information on incontinence, women's health, pregnancy and exercise during pregnancy. Now, we are fully aware that this has not gone live on the Facebook page, and so we're going to be posting this video available for everyone, and then I will be jumping on Facebook to do a live Q&A just now. So if you have any questions, please email them through or jump on our Q&A now. But thank you all for watching and listening. And that is it from us. Anything else from Fiona or Heather?
Well, Jenny, I just wanted to comment that you had glossed quite quickly over your antenatal clinical conditioning program. because when I think of my Pam, if I could have got her into your clinical conditioning program, she may not have reached menopause in such a deconditioned state. So I would just encourage mums to be and young mums to consider that as an option.
Yes. So we've actually adjusted the program to suit women of all ages. So I'll just find the slide that goes through it. So the program has been designed to be appropriate for those who are currently pregnant, who are postpartum, recent postpartum, or haven't had babies for a while, or women who are just trying to improve their pelvic floor function. So we take the pelvic floor into account when we're doing the program. So how to safely exercise if you do have pelvic floor dysfunction, but also how to improve your pelvic floor so that you can engage in exercise more comfortably and confidently. So it's a group class that's held on our Wednesday nights at our Kenmore clinic, but there is an online class option also available. So if you'd like some more information, please send me an email or contact the clinic, and I'm glad to go through it with you more. But doing these things in a group, which thankfully we now can here in Queensland, we can start to be a little bit more social with our exercise, which is very nice and has its benefits included in that. So it's nice for women who are experiencing similar things or in similar life stages, or who have got experience in different life stages or different experiences, to come and engage. And there's a lot to learn. We talk a little bit about diet and nutrition and sleep and mindfulness and stuff as well. So it's a great little class. You get to learn a whole lot of things. But yeah, that's just a little bit more about the class.
And Heather, I wanted to ask you, when you think of so many of our women who are wanting to go to do weightlifting and do high, what is the progression for those women? I mean, if your lady was wanting to run, but what if women are wanting to do weightlifting and power type of activities? What then?
So we'd be building up from their strengthening, making sure that their pelvic floor is functioning well during this, that they're not having any symptoms. From there, we'd then look at building in those sort of power movements, starting off with small versions of it, building up to the point where they can do the full-on power move, and then building up the weight. So it's a nice one that we can work through the whole stages with, from just the general strength training, because power is strength at speed. We start bringing in some of the speed in smaller, more controlled movements, maintaining that pelvic floor activation, and then building up into the bigger power moves that you see the weightlifters use. And if we do it nicely and gradually, then we shouldn't have any concerns along the way.
That's great. That's great. Just one comment on that with my cohort that I covered, the postmenopausal women, weightlifting and power lifting are very important for us. So it's very important that you don't see this kind of training as just for the postnatal women or the antenatal women, but the postmenopausal women need to be moving into this space. Obviously, because our tissue is older, you have to be more careful. But, we didn't touch on it too much when we were talking about Pam, but being able to switch some of those type 1 fibers into type 2, and that's possible with certain training mechanisms, is a great way of helping women keep the speed of action that needed for cough and sneeze and laugh and things like that.
Yeah, I think, the nice way to think about it is there's a spectrum, and where you start on the spectrum is different for everyone, but you want to try and reach that maximum on the spectrum. And so on the lower end of the spectrum, we have things like walking and yoga and swimming, and then on the higher end of the spectrum, we have things like running and powerlifting and skipping. And so if you're trying to get up on that end of the spectrum, you may have to start a little bit lower, but there's no reason through the most appropriate and specific training why you can't get to the maximum on that spectrum. And it's going to be a different journey for everyone. So that's why it's important to have an individualized and specific prescribed program that suits your condition, your history, but also that is going to make you reach your goals. And everyone's goals and aspirations are going to be different. So that individualized program, I guess, is key to making it work and addressing your concerns and meeting your goals.
Mm-hmm.
And Jenny, going through this preparation for this website, one thing that you were reminded of, or that you learned that impressed you about the resilience of the woman's body?
Yes. I think it's for myself. I have not had any children, so I guess it's a familiar topic for me with regards to I guess my occupation, but it's been reassuring for me to know that it's not all doom and gloom. Once you've had a baby, there is hope and there is positivity, and it's such a wonderful experience to go through. And regardless of how you deliver your children or how many children you have, you can still engage in physical activity and still do all the things that you like. And even though I get incontinence is common, so 1/3 of women who've had a baby will experience some incontinence. It's not something that you have to live with for your rest of your life. It's not a sentence. It's just something that happens due to the changes, but you can treat it and manage it. And so I think that's reassuring for me to know that we as women, we are very resilient physically, mentally, emotionally, and that it hasn't put me off having children. Let's just say that.
And Heather, what about you? Can you share, because you are a very active mum, and so can you share a little bit about something that you read in the literature that has encouraged you at this time in your own training?
Yeah, the main one is that all my hard effort, from childbirth, I did have some urinary incontinence straight after my second child, and I worked through that, and I've got back up to running and jumping and doing box jumps, things like that. Probably going to miss the trampoline for now, but the rest of it I can manage, and I don't have any incontinence now. But then leading, I guess my side, I've finished having children. All my physical activity and exercise and things like that are leading me into hitting a spot when I hit menopause that I'm going to be as prepared as I can, that I'm going to have great bone mineral density. I won't have too many fatty infiltrations in my muscles because I'm using them all the time. And that sets me up really well for postmenopause area. So I guess reading about all those things as I'm running now, I'm thinking, oh, well, this is helping me a lot in the long term as well. So that's a really nice one to know about.
Yes, and I must say, because I'm at that brink, I'm not sure where I am with menopause, but things are changing in my body. I really wanted to emphasize that need for building up your it's that whole point that, and this is one thing that was really drummed home with me in the research, is that you have to be able to be accurate and know what you're doing when you think that you're activating your pelvic floor. And so many of us haven't a clue. We just squinch and hope. And so that is one thing I would like women to really get to grips with. Even if it's just a woman who have a beautiful exercise program, but they're not quite sure that they're doing it right, get it accurate, so that whatever you then add, you are using your pelvic floor in an enhanced way. And I know that as I've gone along, I am surprised as I get older, I can lift more weight and I have no stress on my pelvic floor, and I can put the load through my skeletal muscles. I know how to activate my pelvic floor. So, really lovely hope for women of that postmenopausal age and into our 60s and 70s and 80s, and you know, lots of people in those categories.
Oh, I think Fee's frozen.
Lost Fee. Not returning.
Oh, no, I think Fee's frozen. Oh. Right, well, I think I'll finish for Fee. I think she was saying that basically that regardless of your age, there's something that can be done to manage and treat pelvic floor dysfunction to enable you to maximize your function and maximize your fitness. So I guess that's us all done for today. Thank you again for watching, and we apologize again for the technical difficulties that we've encountered in this new technological world of ours. Anything closing, finalising statements from Heather and Fee?
I just would like to thank everyone who's listened along, and if they have anything in common with any of our women that we've talked about, just to, you know, don't just leave it alone. Come and see someone, ask some questions, and you'll be very grateful for it, I think.
Absolutely. I hope we've communicated hope to the women out there who are living with things that they thought they couldn't change, and now we realize that you can. And when you've got a Cochrane review telling you that a specific training can create cure, that's exciting stuff.
I agree. All right, well, we'll sign off here. Thank you again, everyone, for watching on behalf of the Target Physio team, and we hope to see you soon or hear from you soon. But please leave any questions or give the clinic a call or an email, and we'll be happy to have a discussion with you. And this has been recorded, available to watch again or watch in a bit at a time if you'd like. And thank you again. Thanks, everyone.
Thank you.